هو الحقيقة الديبيت ده should have had 3 arms وأنا كنت متخيل كده. always resurface, never resurface و selectively resurface. فأنا التوك بتاعي actually highlight quite a few points ومتفق فيها تماما مع دكتور أيمن، لأن أنا كنت بتكلم على السلكتيف resurface دي patellae، واتفقت معاه إن إحنا طالما إن هو 2 armed debate هتكلم أكتر على ال evidence for each one. كلنا متفقين are all generalization are false, incorrect, including this one اللي هو الكوتيشن بتاع مارك توين نفسه. مش شرط. الباتيلا عارفين كلنا ممكن تبقى always resurface, not to resurface always, or selectively resurface. And I like to be a little bit moderate guy, so I like to go for selective resurfacing. In US, they always resurface, most of them never resurface in Asia and Dr. Ayman Solomon, and sometimes resurface in Europe. And that was basically my training in UK. Both data and authority are available for all strategies. There are quite a few RCTs which would support always resurface versus never resurface. The pros for the routine resurfacing, less anterior knee pain, less reoperation. The cons, fracture, AVN, clunk, loosening, etc. It might be too thin, the patella, too thick, asymmetric. You might get it overstuffed, mal-rotated, mal-tracking. So whenever you decide on doing that, you need to do it right regarding the cut, the side, the position, and the design. Why I personally selectively resurface the patellae? Well, on average, one of the studies showed that 15 to 58% of our knees which we replace having affected cartilage. And it's amazing how many total knees we all do with good cartilage condition, we don't resurface the patella. Reviewing the very famous article by Sharkey et al. About why knees fail, if you analytically look at it, you'll find that the revisions actually related to the patella are quite rare. Common bias among those who routinely resurface the patella is leaving the patella would result in more anterior knee pain and requires more secondary surgery. But we all know that the devil lies in the details. Actually, for those who resurface the patella, they still get some anterior knee pain postoperatively. In one of these studies, it was up to 39%. Again, I came across this RCT, which showed that 28% postoperative anterior knee pain on those who resurface the patella without preoperative anterior knee pain, compared to 14% without patellar resurfacing. And actually, again, one of the other papers showed that with resurfacing, you might get increased strain biomechanically in kneeling and other activities. And also, if you manage to have some tilt, some overstuffing, you might increase the retinacular strain by up to 28%. So it does increase the range of movement, yes. It might increase, then the patellar compressive forces might result in fractures. In addition to the very famous patellar clunk syndrome, we might have come across, especially with older designs, engagement in the box. So whenever we resurface the patellae, if anything goes wrong, the failure would be really catastrophic, and I totally agree with Professor Ayman regarding this aspect. But hold on, we need to analyze why anterior knee pain happens. It's not only through the patella, because I'm sure most of those in the room, whenever they are confronted with postoperative anterior knee pain, they might just jump into the conclusion telling their patient, well, we'll get you everything sorted by just resurfacing the patella. Believe me, this is not always the case, because it might be due to capsuloretinaculum pathologies, impinging synovium, tendonitis, bursitis, bone impingement, etc. So the controversy actually is not to resurface or to resurface, it's the improper, postoperatively improper diagnosis of the anterior knee pain source. Well, again, quite a few studies showed that actually 34 to 66%, this is a huge number, 2/3 of the patient unimproved or even worse whenever we do to them secondary resurfacing postoperatively. There is a caveat here, which you might point, hold on, but whenever you resurface the patella from the start would be better, which might be true. So making like a mathematical modeling depending on different or regarding different studies, if the anterior knee pain would result without patellar resurfacing in less than 14%, and at the same time, anterior knee pain with patellar resurfacing would occur in more than 8%, and the quality of life utility after implant failure, patellar I mean, less than 80% compared to perfect health. So, therefore, not resurfacing works. Again, we always say, well, it's according whether the patella or the cartilage is worn out. But again, quite a few studies of the older studies stating that the status of the cartilage isn't a good guide. I dug into the literature just for this talk. I found this study from Madrid in Core 2010, more recent. They thought that the outer bridge classification, whenever you have grade 4, this might be suspecting or predicting the need for secondary resurfacing. So you could argue that across the board, it's very reasonable for those who like to resurface the patella, but it's also very reasonable to selectively. In my algorithm, I would replace the patella whenever they have severe patellar osteoarthritis, patellar deformity, significant patellofemoral symptoms, and I always tell the company, please, every single case, keep the patella with you. You never know. You might just remember on the day of the surgery, early in the, well, this patient had patellofemoral symptoms. So history is very important. Incongruent tracking inflammatory arthritis, including rheumatoid, etc. Otherwise, use your discretion and resurface selectively. Selectively not to resurface. I came across this rationale as well. Can you imagine? Even in the obese, sometimes they say there is increased risk of fracture, and we all have been there. Trying to reflect the patella, it's very, very difficult sometimes. Expect even more anterior knee pain in these patients with or without resurfacing. In the young and active, I wouldn't definitely, and in the male, I would have lower threshold in the female to resurface the patella compared to the male. Again, if not resurfacing, I would do patelloplasty, i.e. denervation of the patella, obviously resecting the osteophytes, reshaping synovectomy in addition to the role of lateral facetectomy between 10 to 20%. And in a meta-analysis showed that it could markedly, the patellar denervation relieve anterior knee pain. And now we are in the era of the concept patellar-friendly designs or concepts, and I came across this study in 2021, and they stated that now with the current designs, it would outperform others even if you leave the patella not resurfaced. So in summary, in these couple of slides, how I look at it personally, no consensus favoring one strategy over the other. They claim that anterior knee pain and reoperation, but there isn't any evidence that the anterior knee pain is typically related to non-resurfacing of the patella. Sorry. And so, because we need to dig into the actual cause of the anterior knee pain, which might happen because of the patella or other reasons. And also, the patellar resurfacing might be associated with a lot of complications, costs, or time. So most of the meta-analyses and the level 1 studies, no significant difference, especially when it comes to the clinical functional outcome. So I would end with, routine resurfacing isn't necessary, only in specific indication and selective patients. No strong arguments to favor one on the other. The final decision is based on your practice, training, experience, proper history, examination of your patient. But if ever needed in selected indications, please do it right to avoid complications. Thank you very much.